kind of just an interesting technology in medicine, right? So Spallanzani, he was an Italian scientist and priest in the late 1700s. He studied bats, and he hypothesized that bats relied on sound, not vision, to navigate. And how he did that was he actually poked out their eardrums or their eyes and saw whether they could fly appropriately or not. And he noted that if he actually took out their eyes, that they could still navigate. But if he took out their eardrums, even if it was on one side, and took away their ability to hear, that they could no longer navigate. So he then was the first person to sort of understand that some animals use this idea of echolocation, or seeing through sound. And then there were several other experiments that sort of leading up to where we are today, but water is a better medium for sound than air. This was the famous Swiss physicist and mathematician who discovered that the speed of sound in water is faster than the speed of sound in air, significantly so. So if you look at 20 degrees, and it changes by temperature, but at 20 degrees Celsius, the speed of water is 1,481 meters per second, and air is 343. So things can travel, the sound can travel much better in a water medium, and that becomes relevant for us in our medical ultrasound. The observed frequency of a wave depends on the speed of the source and the observer. So this is the Doppler shift. I won't go into details. We've all learned this in physics. Yep. And then this is like the big discovery. So the piezoelectric material, this was discovered by French physicists that were brothers in the, let's say late 1800s. So they discovered that when mechanical stress, such as sound, is applied to certain materials such as quartz or tourmaline, there's other materials in this list, but electricity can be produced, and vice versa. And this is the basis of the modern ultrasound machine. So this is called piezoelectricity. And then here we'll just talk about, this is at a very basic level. It is not at the level that Miley probably knows it at, but this is a very, very basic level of how you can understand how the machine works. So here you have electricity going into the probe. You have piezoelectric crystals here, right? So some piezoelectric material that is then converting the electricity into sound waves. The sound waves go and they interact with tissues within the body, and then some sound waves return because the sound waves can reflect if they hit a hard surface, or some sound waves never return, like in fluid, they just keep going. So that is the basis for the ultrasound machine. So now let's go, of ultrasound imaging. So it's called acoustic impedance. How well or not well do sound waves travel through the material? So here you can see if it's fluid, right? If there's no solid, it's purely fluid, the sound waves travel all the way through, they are not reflected back. And so that's why they turn up black or anechoic, so no echoes are coming back. So anechoic, so fluid, including blood that has not clotted off, because clots can look differently, and this becomes relevant in, for example, hemothorax, when you are going to look at lungs in trauma patients. If you're doing a pulmonary exam and you see big clots below, you know that that's a hemothorax. Okay, but if it's just a trauma patient that has anechoic fluid around the lung, could that be blood? Yes, absolutely. And it's very important to teach trainees this, because I think, we had a case actually here where a patient had hemoperitoneum, and it was a case where a woman had VOD, was being managed outpatient. She had young children. She herself was very young, sad case. And she was getting repeated taps, and only 2 liters was removed, but she had this delayed bleed. She was hypotensive, and the fellow scanned the belly, saw free fluid, and thought that the ascites had reaccumulated. Unfortunately, it was blood that was accumulating, and they thought, oh, this is before our ultrasound course, and they thought, they knew just enough to know that, let me check, but then they didn't know what to do with that. They thought blood can't be anechoic. For some reason, that's what their conclusion was. And so anyway, in any case, that patient ended up dying, and it could have been an early recognition, which is why we use ultrasound. So blood is anechoic. It is fluid in its fluid form.
Sadia, so we noticed on echo, especially in pediatric or young, thin patients, that inside the ventricles, right? It can be, instead of being black, you can see echo dense stuff, and it's not. We suspect that like maybe now with the machine they try to like optimize everything and then like just enhance stuff with a harmony or something. So now we actually, it's not completely black in some patients.
Like
So
in the ventricle itself.
in
Do
the
you think you're
cavities.
getting you're seeing more than you are used to seeing in an adult patient in terms of the they're so thin that you can actually see, you know, the trabeculae and other things, or do you think?
Yeah, no, it's more than trabeculation.
Okay.
You know, inside the cavity,
Yeah.
it looks almost like you get contrast, like that
Wow.
spontaneous
Okay.
echo contrast.
Yeah.
Sometimes you see a little swirling,
Yeah.
like blood moving. Yeah, so I don't know. It's just like somehow either the pediatric probes or in certain patient, everything it just enhanced so much that we don't.
You see something
You-
in there.
you
yeah.
see stuff,
Overall
yeah.
anechoic, but some sort of almost like
In
what you would
some
have seen in bubbles.
patients, the entire cavity is like white. Like
Wow.
Yeah.
That is really surprising.
Right. Yeah.
And this is with routine echo machines?
This is with routine.
Wow,
yeah.
okay, that's very good to know.
Yeah.
So, but in general, and with the machines we're using, which are not $100,000 machines, $160,000 machines, we're using 60,000. 200 now. We're using like 40 to 60,000. Our machines will pick up only anechoic, okay? So, but it's good to know. Okay, and then so when you get to like soft tissue, right? Most sound waves go through. Some are going to be reflected back to the machine. And as you get more and more dense, right? So dense tissue like fascia, you're going to get more of that reflection back. So it's going to appear brighter. And now bone does this funny thing. Solid things like stones, like gallstones, kidney stones, and bone will do this funny thing called shadowing. And it's relevant for thoracic imaging because you need to be able to identify ribs. And ribs have shadowing posteriorly. So what happens is you have the sound waves get entirely reflected back. None of them get absorbed or propagated through. So you see the bony cortex, but then there's shadowing behind it. That's not fluid, right? I just told you fluid is anechoic. The shadowing effect is behind something very bright, like a bony cortex. And actually, if you do international work, this might be your sole way of diagnosing fractures in people, especially thin patients. Obesity is largely like, I mean, I hate to say it's largely an American phenomenon, but like in a lot of other international places, you actually, this will work instead of x-rays because the patient population is so thin. Okay, so so that's that. Do you have any questions about this or, okay. So ultrasonography enters the medical scene in the 1940s. There was an Austrian neurologist, and I mention this because everyone thinks of ultrasound and they think babies and heart, right? But actually when it first came about in the medical field, it was other uses. So Karl Dessig, an Austrian neurologist, right? He first published on the possibility of using ultrasound waves as a diagnostic aid. And they were thinking about like whole body ultrasounds. Douglas Harry, American radiologist, on the detection of intracranial pathology by ultrasound. In the 1950s, Ing Edler is considered the father of echocardiography. He's a Swedish cardiologist, and he published the use of the ultrasonic reflectoscope for continuous movements of the heart wall. And then it was 1958, it was the last thing actually, American obstetrician, and it wasn't for babies, the investigation of abdominal masses by pulsed ultrasound. So it entered the medical scene in the 1940s to 1950s. People were publishing on this. This is one of the first machines that was used. So you can see they had to sit in an entire vat of water to visualize anything. So can you imagine being that patient? But 1950s, cardiology and obstetrics really ran with it. They said this is really useful, and they took it and they actually developed ultrasound use within their practice. It wasn't until the 1990s, so this is in the United States. In the 1970s and 80s is when Europe started using ultrasound for trauma patients with the FAST exam, the focus assessment in trauma patients. So that exam became popular in the 70s and 80s in Europe. They're a decade ahead of us. Right now, if you go to a primary care physician in certain areas in Europe, they will use an ultrasound. We are not yet there. We're trying to still use it in the ED and in the ICU, Emergency medicine and trauma surgery really started using it in the 1990s. Critical care medicine, not till the 2010s, really. Like, it's been relatively recent. And now internal medicine is starting to get interested. And part of that is because the usability of these ultrasounds, the portability, I should say, is improving. So in the 1960s, you saw that like vat of water. The 1990s, you had these big cart-based machines. And today, I mean, we still have the cart-based machines because it's better visualization on them. But today we have, and this is already outdated, right? So that's describing the butterfly where you can actually plug into your phone. Well, now we have wireless. There's several wireless options. So it just keeps getting better and more usable. And so actually we're at an inflection point in medical history at this point. In 2014, they surveyed 28% of medical students were being taught point-of-care ultrasound, and now in 2021 it was 72%. Now I think this number is probably 100%. I mean, students are actually looking for whether there's an ultrasound track within their programs, et cetera. And so we're at this point where everyone being trained is familiar now with ultrasound. And this has been a problem because some of the older faculty, a lot of the older faculty, did not train with ultrasound, and they don't incorporate it into their practice. So now trainees, I can tell you, I teach nationally at this ATS course, and every year I ask the attendings why they're taking the course, and they say, because my trainees are showing me images I can't understand. And so now the senior folks are starting to get interested in it. But I also want to point out that point-of-care ultrasound is a distinct entity than consultative ultrasound. So there's a New England Journal article, oh my God, I'm blanking on his name, but he's a cardiac anesthesiologist that does a lot of the TEE stuff down in Texas. He actually wrote about this because people need to understand, and we need to be able to refer people to something like this. Now, this will be relevant, I think, initially while you're doing point-of-care ultrasound for lung, like in addition to your, because you have some protection to say, actually, this is different than consultative ultrasound, where the test is ordered by the clinician, performed by a technician, interpreted by a consultant who is not directly involved in the care of the patient, like the cardiologist or the radiologist. This is direct interaction between the clinician and the patient to establish a clinical diagnosis or guide a procedure. So this is both of you just like at the bedside interpreting it, right? Is Ron on the other side? Ron? No? Okay. So anyway, so this is an important point just to be aware of, because there's other issues downstream from this, right? Legal issues. People get worried. People get worried about point-of-care ultrasound. They're like, there's an image. This image could now mean that you, if you don't have it uploaded into your chart and you haven't formally, written it's a diagnostic image, so you have to do something about it. A lot of people in the POCUS world, like me, argue that actually no, it's kind of like the modern stethoscope, right? It's like, if you listen for lung sounds, you take my word for it in the chart. You should take my word for bedside ultrasound. I don't always have the time, especially in the ICU, to like upload all these images, and we're going to be like crashing our IT systems by all these extra images if we start to do them. And actually, there's an ER physician that's done 2 of these studies now, where they actually, I think they're like an MD, JD, one of those people, and they went back in time and looked at all lawsuits surrounding ultrasound, and actually the non-performance of ultrasound has been implicated, but never POCUS causing a lawsuit. Does that make sense? So like not doing it, like it was indicated, why didn't you check for pericardial effusion, or why didn't you check? So that is more, that puts you more at risk than actually doing the ultrasound itself. So and I find it very simple. You just tell the patient at the bedside, this isn't going into your chart, you're not going to be, this is something for me to just assess you better than my stethoscope. And they understand that. So could ultrasound replace the stethoscope? This is in 2023. I mean, this was a New Yorker article. The public is starting to become more and more aware of the kind of head-to-toe use of ultrasound by physicians. And this is Chris Moore at Yale, who said, while unlocking the full potential of ultrasound may require substantial training, even novices with POCUS outperform experienced providers who are using the classic skills of auscultation and physical examination. And that makes sense, right? Like, now when the fellows tell me diminished breath sounds, I'm like, but you can tell me if there's a consolidation or an effusion or a pneumothorax, or, right? Like, why are you telling me just diminished breath sounds? And so anyway, it makes sense. So I just very briefly, how did I get into ultrasound? It's life-saving in resource-limited areas is what I found. Everywhere I traveled, refugee camps, completely rural area in the Congo where there is no, there's not even enough food to feed triplets, so they're feeding one of their 3 children. There was ultrasound present. I mean, like, people donate their ultrasounds, and people have found in the medical community, somehow in the international medical community, the value of ultrasound. You don't have x-rays, you don't have MRIs, you don't have anything else, but you can get an ultrasound, and as long as you have electricity, you can get it to function. And so this was a 22-year-old Congolese male harvesting cacao, and he had ankle pain and a limping gait. That's what he came in for. And this is a ruptured tendon. His Achilles tendon ruptured. So I was able to do ketamine and ultrasound guided distal sciatic nerve block and Achilles tendon repair. I casted him and he was able to walk again. And this is something that otherwise we wouldn't have known. Does he have an ankle sprain? I would have left. I wouldn't have been able to fix it, right? So this is huge. This is a 19-year-old female in Haiti. She complained of abdominal distension for a year. And she said that she was pregnant, but her her neighbor had done voodoo, on her, preventing the birth of her child. And so she was counseled, because here is her uterus, completely empty, there's no baby inside, but she has massive ascites from something. So she was referred, note in hand, transported to the city hospital for further workup. But I was able to show her, like, you don't have a baby, actually. This is, empty, and et cetera, et cetera. Okay, but I saw the value of ultrasound in all of my international work, but I just continued to use POCUS here and realized, like, this patient would have died if I didn't ultrasound them. This patient would have died if I didn't do that. So it happened over and over and over again in these cases where I finally was like, we have to be teaching this. We have to be teaching this. Whoever will listen to me, I will talk to them about ultrasound, because for me, I know that downstream it's saving patients' lives. So that's why I'm passionate about teaching it. Okay, so now getting to probe selection. So that's some of the background leading to this. So probe selection, there's 3 probes. You're gonna see them on our machine down in the ICU. I think you guys only have this machine on, right?
We have that, but I think we used to have linear too, but
not anymore?
No.
Okay, so that, if you're doing lung ultrasound, if you're doing it for B-lines and pleural effusions, you'll probably be fine with just the phased array. Linear is really good to have for pleural assessments, and yeah, so but you can get by for now, for sure, with just the phased array. You'll just need the software package for your preset being, lung or abdomen. Abdomen. So the probe selection, so this one is called the linear probe. It's this long sort of, you'll see it on the other machine, it's this kind of long, thinner, flat probe. And it is the highest frequency probe that we have, so it's generally like 5 to 15, or even higher actually, let's say like 8 to 15 megahertz. The curvilinear that we have is 1 to 5 megahertz, and phased array 1 to 5. The reason I mention that is because, right, so this is high frequency, better for superficial structures. It doesn't travel so well deep, but it's a higher resolution for those superficial structures, so you see more because it's higher frequency. The lower frequency, think of like a foghorn, right? Like, it's not high pitched. The lower frequency travels further.
Just a longer wavelength.
Yeah.
Makes it go further.
So it travels further, and so just like that, the sound waves travel further in you with the lower frequency probes. And so those are on our machines, at least. Those are the settings for the frequencies. So higher frequency, better resolution, can't penetrate well. Curvilinear, lower frequency. It has this large footprint. We call it the abdominal probe, because you can see the abdomen. It's really the least preferable for chest imaging. And the reason is because the shadows, the rib shadows, when they happen, you'll see them. You're trying to see the pleural line here. and you'll see that the rib shadows can go like this and like completely obstruct your view. Whereas if you use a phased array probe, the phased array probe or the cardiac probe is low frequency, small footprint to fit in between rib spaces. The crystals are arranged in such a way that you actually, from a small footprint, get a wider, right? So it's like optimal imaging for the chest. So linear frequency, and we'll talk about exactly in the thoracic cavity when you want to use linear, when you want to use phased array. Okay. Just one quick note, you should be able to look at your machine and or any image and tell me whether you are using a phased array, a curvilinear, or a linear probe, just based on the image. And just get used to seeing that, because every once in a while it's like you're using the wrong probe or something, and then you're like, oh, well, why can't I see so well? And you're like, oh, I'm holding a curvilinear. Like sometimes just looking at the machine itself, it's just one extra thing that's helpful so you can see, right? Any questions there? All right. Clinical applications, so head to toe scanning, we talk about all of these other things, like when you would use phased array. The optimal imaging actually for thoracic is linear, because in most patients are thin enough that you can see the pleura well. In some cases, even with they're obese, you want to focus more on A lines, B lines, you'll learn about all what that is, or consolidations or effusions. Then I switch over to the phased array and image from below. And we'll talk about that. The cardinal movements, you have to know this. So sliding, what is that? That's just sliding the probe. And the reason is because when you're training, but also when you're like seeing videos, seeing, reading the literature on how to get the best image, it'll say things like slide the probe this way or tilt or fan, so you need to understand the movements. So sliding is just what it sounds like. Rotating is what it sounds like too, just rotating the probe 90 degrees, that's pretty straightforward. Tilting and fanning is a little bit more, just takes a second, and then rocking as well. So tilting or fanning, say this is the probe, right? So tilting or fanning, I say both, because in the cardiology world, they use tilting, right? You guys use tilting. Tilting, T. Tilting is where the tail of the probe is going. So the tail of the probe is where the plug comes out from, or the cord, thank you. Not the plug, it's the other part. The cord comes out from. So T for tilting, so you tilt down, tilt up, right? In the ER world, where a lot of ultrasound comes from, fanning is what we call it. So fanning is where the ultrasound beams are going. So when you tilt down, are you fanning up or down?
Fanning up.
Yeah, you're fanning up, and then when you tilt up, you're actually fanning down. But we often say like fan through the structure, and that means put the ultrasound beams all the way through the structure. So that's just so you know, that's tilting and fanning. And then rocking the probe is going perpendicular to where the probe is. So the probe is here, and so you're rocking the probe side to side, right? So like rock to the right, rock to the left, that kind of thing. Okay, so rocking, rotating, tilting or fanning, and then sliding. These are the movements. And then planes, I think this one, just one comment on it, you guys know sagittal, coronal, transverse. It's just that a lot of organs in the body do not have like a perfect vertical or perfect horizontal lie, right? So we just use the terms long axis and short axis of an organ. So the short axis is perpendicular essentially to the long axis. The longest part, the maximal length of the structure. Does that make sense? So like your kidneys are off axis, your heart is off axis, so we just use the terms long axis and short axis. Okay. Knobologists know to power the machine on, select a probe, and then there's application presets, so abdominal, cardiac. We're going to practice that when we do our practice with Neha. But there's different presets. When you're doing thoracic imaging, there is a lung preset on the linear probe. That is the best to visualize the pleura. So when you're looking for a pneumothorax or pleural abnormalities, or you're looking at a pediatric patient for pneumonia, you're going to be using a linear probe. When you want to look for effusions, so effusions are gonna layer posteriorly, they're dependent, right? They're fluid, dependent on gravity, and so they're gonna come to the bottom of the lungs here, especially if you're head of bed up, anything like 30 degrees, right? It's gonna come down here. So you wanna look at, you wanna image down here for your pleural effusions. And that's where I start to assess for B-lines also, and then move up and see how high up they're going. It's kind of like the sonographic rails assessment. So instead of like listening for rails and seeing how high up they go, I look for B-lines and see how high. And so anyway, in most cases, you have to be, unless the patient is exceedingly thin or a pediatric patient, you switch to the abdominal probe, or the cardiac probe, but in the abdominal preset, because you need to kind of go in deeper, and we'll talk about that. Place gel on probe and place over anatomic area of interest. The gel is very important, and that is because people think it's a lubricant for the skin. That's not what it's being used for. You actually need to use a good amount of gel, because if you're doing things like rocking your probe or tilting, you will come up off of the skin and you will lose contact. Remember what I told you about air? Sound waves scatter more through when they hit air, so you will not be able to see an image. In fact, especially when you're first learning to scan, I always say, if you can't get the image, just hold steady, because then look back at your hand, and often you'll be like, oh, I came off, I didn't use enough gel, or you can troubleshoot a little bit about what's going on if you lose your image.
So Sadia, there's no lung preset? There's only cardiac?
There is a lung preset in the cardiac, but it's set to best visualize the pleura.
Oh, okay.
So instead, if you actually want to look at an effusion or look for B-lines, it's best to be in the abdominal preset with tissue harmonics off.
Okay.
So, and I was going to talk about that in just a minute, but basically, we can jump there. So this is with tissue harmonics on, this is tissue harmonics off with the abdominal probe and the abdominal preset. And you can see you can pick up more B-lines, and they become sort of clearer with the filters off. And this is, so in lung imaging, you actually want to see artifacts. You want to see things that normally in abdominal imaging you don't want to see, right? So artifacts are distortions or false images that can appear during ultrasound exam. They're caused by errors in sound wave interactions or machine settings. And so basically everywhere else you kind of don't want the artifacts, you want to see the organ. But in lung imaging, because it's all air beyond the pleura, we can't see anything well, right? We're sort of looking for the artifacts. We're looking for those A lines, which are reverberation artifacts. We're looking for B lines. So we're looking for those artifacts, and so we want to take off anything that in the imaging, in the machine, is a preset to prevent artifacts. We want to allow them. Okay, so that's the whole idea behind that. And so shadow, I think we talked about some of this. So shadowing, what happens, posteriorly, you're not going to get any image. Mirror image, I think is just important to know, because in thoracic imaging beyond the lung, when you have, this is an important point for lung imaging. So when you have the diaphragm, you will see across the diaphragm sometimes, we call it a mirror artifact, because that's what it is. You'll see what looks like the liver, because on the right side, the liver is right below it, and you'll see liver above. And that's not hepatization of the lung, where you have a dense consolidation, and so therefore it looks like a solid organ. That is just a mirror artifact, and it's very reassuring. And the way that I confirm that is by doing a spine shadow assessment, and I will tell you all about that in a few minutes, okay? So again, probe selection, going back here for a minute, good for visualizing lung sliding or pleura is your linear probe. Good for visualizing A lines, B lines, pleural effusions is your phased array probe. Okay. We talked about filters on, filters off.
Were obtained at the same time from the same location on the same patient. The B lines are far more evident in the far field in the clip on the right, where speckle reduction and compound imaging have been turned off.
Okay. And where do you image the lungs? So in general, we start at the top because that's your pleural assessment, your pneumothorax assessment. And so you look for, we're gonna talk about what you look for, but you look for lung sliding there. And you generally just wanna go rib space to rib space down. When you get to about the top of the chest, essentially, some people will say like right at the nipple line, you start to come out laterally, but even some in women, you would just stop essentially at this point and come out laterally here and start to go into the axilla and scan down there. And there are specific locations. You can go like all the way posteriorly back. They recommend doing that. There's something called a Plapp's point, which we can talk about with further talks, but for now you don't need to know that. But it's basically like just image rib space to rib space down, and then when you get to here, come out laterally and image all the way down until you see the diaphragms. So that's how we do the imaging. And and here's, is this one of the videos? No, okay. So here's what you see when you first put, and is this a linear probe or is this a cardiac probe? Do you remember the phase chart?
Linear to me, yeah.
Yeah, it's linear because it's got that square image, yeah. And you could take these slides from me if you want, so that way you can have them also for reference. So the soft tissue, right? So actually in this, it's a little too bright, so you don't see it well enough, but this is a rib, and this is a rib. And so beyond that, you have acoustic shadowing. So you see the shadowing posteriorly, and that is how you identify the ribs. And it is extremely important because you can mistake one of these lines for pleura and say the patient has a pneumothorax and then stab them with a needle and actually give them the pneumothorax. So it's important to first say, this is the pleura, especially in obese patients. It's like, sometimes it's like much deeper than you realize. So you must find the ribs in order to say in between that is the pleural line. So that's one very important
And the pleural line always look below the rib line?
Yes.
Okay.
Yeah.
Are most commonly imaged in a window that visualizes the ribs and intercostal space. The ribs have a hyperechoic cortex and cast shadows deep to them because ultrasound waves are reflected by bone. Deep to the skin, subcutaneous fat, and intercostal musculature lies the pleura. Ultrasound is not sufficiently sensitive to reliably discriminate between the parietal and visceral pleura. As a result, the interface of the parietal and visceral pleura appears as a single hyperechoic line just deep to the ribs.
So if you, this is gonna take you back to med school probably, but so the chest, the thoracic cavity is lined by parietal pleura, and then the lung itself has visceral pleura, and so that's what he means by the two pleuras. You can't tell the difference between the two, but that's what makes that view of lung sliding. It's actually the two pleura sliding against each other.
Diaphragms appear as curved hyperechoic structures that conform to the cephalad margins of the liver and spleen. Mirror image artifact can be noted cephalad to each hemidiaphragm due to the reflection of sound waves along a curved interface with a dramatic difference in tissue acoustic impedance. The hemidiaphragms move craniocaudally with respiration and are best visualized at the end of the expiratory phase, where they are least obscured by air artifact from the lower lobes of the lung.
So, remember we talked about as the tissue gets denser, it becomes brighter. So the diaphragm is quite bright, and you're going to find it right above the liver or right above the spleen. So anatomically know where that is, and it'll be right above that. And it's a dome-like structure, and it's very helpful in things like in the ICU where patients have diaphragmatic atrophy. They're looking at a lot into this. Diaphragmatic atrophy from being intubated too long. You can sort of predict weaning failure. These are very early studies, but you might be able to predict weaning failure and things like that from the vent with this. And then and it is such an important thing in terms of identifying it to see pleural effusions, because a small effusion may not be further up, but you have to identify the diaphragm, and you can sometimes even see these trace effusions, often see these trace effusions.
So in those patients, is the diaphragm just less bright?
Yeah, so you can actually, that's a good question. So there's two things we look for: diaphragmatic thickness. So it should be thickening by a certain amount, or you actually M mode it. So M mode is motion over time along a chosen line, and we'll practice that in the practice session. You'll see it actually, the ultrasound will draw up a line for you, and you can adjust that line to where you want it to be, and then hit the M mode button again. It'll graph motion along that entire line. So if there's any movement, you'll be able to see it. So with diaphragm, you see the diaphragmatic movement, and if it's if a patient's diaphragm has atrophied, it is just not moving as much. And there's certain cutoffs there. Okay, so again, rib, pleural line, acoustic shadowing, you guys see that? Okay.
Sliding refers to the sonographic appearance of the pleural line during respiration. Lung sliding results from the visceral and parietal pleural layers moving past each other during the respiratory cycle. Recall that the parietal pleura is adherent to the inner chest wall, while the visceral pleura is adherent to the lung itself. These two move past each other during inhalation and exhalation, seen on ultrasound as lung sliding. Lung sliding is a normal finding. Note that during breath holding, no lung sliding will be observed.
Very important for when you intubate a patient and you don't have an x-ray machine, or you can't wait for the x-ray, and you just gave this patient paralytic and a sedative to intubate them, and then I've seen people looking like, oh, they don't have lung sliding. It's like, no, you have to bag the patient because they're paralyzed. So anyway, that becomes relevant in the ICU. So here, so lung sliding, you saw what that looks like. People call it like ants marching, or I don't know what else it's called, but like you sort of see that like movement essentially, right? Here, I think it's an example of not lung sliding, but let me check.
Sound clip shows the to and fro movement of the pleural line that is synchronized with respirations, which is termed lung sliding or the sliding lung sign. The pleural line, indicated by the arrows, literally appears to slide back and forth across the screen. The movement is striking due to the motionless appearance of the surrounding structures. Of note, lung sliding may be absent in pathologic conditions such as a pneumothorax, emphysema, or hyperinflated lung states, and following lung pleurodesis.
So now you can see the difference between the two.
Previously, lung sliding is a normal phenomenon that one expects to see during respiration. When lung sliding is not seen, it can mean several things. Either the lung is not inflating and deflating, the visceral and parietal pleura are not touching, or the visceral and parietal pleura are adherent to each other. The pathologic conditions that produce these circumstances will be discussed in great detail. As long as one remembers the basic physiology that produces lung sliding, these pathological states can be deduced.
Okay, and this is...
Pulse is defined by the absence of lung sliding and the perception of cardiac pulsation at the pleural line. A lung pulse differs from lung sliding. A lung pulse is characterized by very limited to and fro movement, often described as a shimmering appearance. Importantly, the rate of movement matches the heart rate rather than the respiratory rate. These two ultrasound clips demonstrate a lung pulse on the left and lung sliding on the right. Notice the shimmering movement timed to the patient's heart rate on the left as compared to the obvious sliding of the pleura in the right image. There is little doubt that there is significant sliding back and forth across the screen.
Okay, that was a longer one. So if you just intubate a patient, so you're in Vietnam, you're at the NIH, right? Somebody just intubated a patient, and you're showing there's no x-ray immediately present, right? And this patient is desatting, right? And you want to see if you're in the right, location. You can listen for breath sounds, sure. Is that the best thing? Not really, no. You actually, with this, there's lots of noise in the ICU and things like that. You may not be able to hear well. So you take a look with the ultrasound, and you see lung sliding, you're bagging, and you're able to see lung sliding on the right, and you see this, you see a lung pulse on the left. What does that mean?
Yeah, right being stamped.
Yeah. Why do you say that?
Well, because you're seeing lung sliding on the left, which means you're ventilating on the left, but I'm on the right. When you see lung sliding on the right, you're ventilating on the right, but on the left you're not ventilating, but you've got heart
Yes,
pulsating.
the patient's still alive, so you can see
yeah.
the cardiac pulsations. That's just heart pulsations that are being transmitted to the lung. So with the heart moving, the lung is just moving a little bit. So it's not that you have a pneumothorax. In fact, if you actually see a lung pulse, you've ruled out pneumothorax. The fact alone that you can see these little bits of, this is actually, it's not technically, you can't call it lung sliding, but it is little lung sliding movements. It is technically what it is. It's a visceral and parietal pleura going bloop, 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 right with every cardiac movement.
And so
but you're not ventilating that lung. So you're not ventilating that lung. That tube has gone into the right main stem. So you need to pull back the tube. So that, and then you would confirm that, yes, I do have lung sliding now on both sides. This has happened to me post-op. Patient comes back to the ICU. I'm like, why are they desatting? Take a look. Actually, their ET tube was. Then I look at the positioning of the ET tube and how much further and everything, and it's like, well, now they've been right main stem while they were down in the OR. Not here, community hospital, where I'm in light.
So lung pulse, like, is you see that in the absence of the visceral and parietal movement, but you have that movement because of the lung inflating and deflating. So in the absence of that, just mean that there is no inflating and deflating, and it could be due to different causes.
Yes.
Okay.
So let me just get a better one. So if you have the tube in too far here, and you're only ventilating this lung, you're going to get great lung sliding here.
Right.
Here, you're not ventilating this lung, so there's no air movement. The lung is not inflating and deflating, but the heart is just sending these little pulses. Like the heart is moving, and so because the heart is moving, the pleura just are moving a little bit. And so that's the lung pulse, right? Now, what other conditions you had just asked me? Yeah. Well, if you are a patient with a pneumonia, you can have some blockage here. You have let's say it's one of your CAR T-cell patients in Vietnam and post, they are thrombocytopenic, they bleed into their airways a little bit. Now they have a little bit of a blood clot that's sitting here, right? Or they've developed pneumonia, and here they have a clot here, or mucus plug, and their whole lung goes down, right? Their whole lung goes down, is collapsed. You are not ventilating this lung. But the patients, but you will see is this little movement. Even on the right side, you can see lung pulse. Okay. You will see lung pulsations, and you can monitor their pulse and see that it's the exact same as the heart rate. So you will see lung pulse here, and you will see good lung sliding here.
So lung pulse is equivalent to absence of lung sliding.
I hesitate to say that. They call it lung pulse different from lung sliding, right? It's technically very.
It's still some sliding.
Yes, it's very minimal. So you can't call it lung sliding, but it is lung. It's movement. Let's say it's still pleural movement you're seeing. And it's the pulse. It's from cardiac movement. That's why it's called pulse. It's what's moving is the heart.
But it just means basically anything that causes the absence of ventilation of the lung. Is that fair to say?
That is the perfect way to say it. So lung pulse signifies a lack of ventilation of the lung. Absolutely. So so mucus plugging. This is mostly when we see it actually, and what I just described right now. So if you see a lung pulse, I answered this question earlier, but Chris, if you see a lung pulse, can you rule out pneumothorax?
Yes, you said that. Yes, because if you shouldn't see a pulse if you got pneumothorax.
Yeah, because you're still seeing a little bit of movement, so that means the visceral and parietal pleura are abutting, right? They're still touching. Okay, let's see.
Of a lung pulse rules out the presence of a pneumothorax under the transducer, as air would preclude its sonographic visualization. In this ultrasound clip, some shimmering or pulsation is seen. Therefore, there is no layer of air within the pleural space. There is no pneumothorax under the transducer. Since there is no lung sliding visualized, It does not appear that the lung is expanding and contracting at this location. Keep in mind, this is just true for the lung you are scanning, not both lungs. The presence of a lung pulse is also seen with main stem bronchus intubation or marked atelectasis, when consolidated lung transmits cardiac oscillations to the pleural surface.
Good?
Yeah.
Everyone understands that point? Okay. In your ICU, or in, let's say, in Vietnam, in this ICU, they just place a central line, right? And they just intubated the patient. How frequently does that happen? All the time, right? Because the patient's decompensating, you do those things together. To a central line, you do intubate the patient. So they just place a central line, and now the patient is desatting. So you take a look with the ultrasound, and you say, actually, you didn't puncture the lung with your needle doing the central line. That's one of the risks of placing an IJ is pneumothorax. You don't have a pneumothorax. I see a lung pulse. Your right main stem pulled back, right? It's like so useful, immediate. You know, this is why when I said to you, like, in the ICU we need ultrasound. It's like this is. It's like you can pick this up in seconds. Okay, pleural. Wait. Let's see. This must be something that they're showing us here. No? Okay. This is again, I think, just the same image. Pleural line, rib shadowing, and then we start to talk about A lines and B lines. Okay, let me go back here. A lines are, what are A lines? They're an artifact. They're an artifact we want to see. They're an artifact that signify normal lung because they signify air in the lung. So what happens is the sound waves go, they hit the pleural line, which is very bright, and then there's air posteriorly. So the sound waves scatter once they hit air. So there's nothing posteriorly that can be made. So the machine is like, it's probably the same as what's up here. So it does this reverberation artifact. So it's equidistant, as you can see. You can actually march out these A lines. So A lines are reassuring, they mean air. It's a well aerated lung. When we do NAHAS, hopefully she has A lines.
Hyperechoic, vertical lines that arise at the pleural line, move with respirations, erase the normal A-line pattern, and extend downwards off the screen without fading. While the occasional B line can be found in healthy lungs, the presence of multiple, typically more than 3 within an intercostal space, B lines indicates fluid, inflammation, or fibrosis in the alveolar interstitial space, and is seen in patients with a variety of pathologic lung conditions.
We actually used to just call it pulmonary edema, and then now in the ultrasound world we call it alveolar interstitial syndrome.
Yeah, that was kind of my question. It's like, if we see B line, what can we write in the report?
Yeah, so B lines. So alveolar interstitial syndrome is now what it's called because you can see B lines if there's anything in the alveolar. So what are B lines? B lines are kind of like micro reverberation artifacts. It's called a ring down artifact. And it's like sound waves, some are filled with air, right? And so they reflect in these small spaces, or they, don't propagate, they scatter. And then some are filled with fluid, so the sound waves come through. So you have this kind of like reverberation back and forth in these like at the micro level. And so it comes down, it's the best way I can explain it. So ring down artifact is what it's called, right? So you kind of have this back and forth because some things at the level of the alveolar, some are filled, some are not filled. Some are filled with air, some are filled with fluid or pus or, blood if you have DAH, diffuse alveolar hemorrhage, or fibrosis because you had ARDS, okay? So they're filled with something, and so you get this back and forth, and so you get the B lines. A lot of times it's just fluid, so we call it pulmonary edema, right? It's hard to know what is in the alveoli, and that's you contextualize it clinically, but that's a B line, okay?
Can I ask you a quick question?
Yes.
So because it's called alveolar interstitial syndrome, right? So that means there could be stuff in the alveolar or in the interstitial space that can also cause B lines.
Yes.
Is that right? Okay.
Yeah.
So the best way is like B lines are present in suggesting alveolar interstitial. That's how we should write it in the report. Okay.
Yeah.
So you can think of it as just, sound travels faster through fluid than it does through air, right? So it's just, you get to sort of hyperresonance when you have the presence of fluid, right?
Yes, and actually this is it. This leads me to an important point in ultrasound imaging because I told you sound waves scatter when they hit air, and you won't be able to produce an image, right? But a lot of what it's a little bit more complicated than that, and it's really the interface between different, so acoustic impedance really is like, it's how sound waves travel in material A next to material B. So it's a little bit more complicated than just like air, no, fluid, yes, right? So now if you have air bubbles within fluid, what happens? So you see this all the time. So why air scatters, I told you, if it's major air, like if you have subcutaneous emphysema, you guys know this, you can't image the chest, you can't look at the heart. You know, then Chip comes and yells at us, like, patient has subcutaneous emphysema, I can't see anything. And we're like, just do the subconscious. You know? So sometimes there's that, right? So, but when you're surrounded by fluid, think about what's going to happen. The sound waves are going to actually come down. They're traveling really great, and all of a sudden they hit this, and it's like, well, the machine says, well, I hit something hard here. So actually they get reflected back because it's otherwise they're propagating well.
Yeah.
And so it appears as hyperechoic. So little air bubbles. When we do the bubble study on echo, you should watch it one time. It's actually kind of cool. You agitate the saline, you push through the line, and you'll see these bright bubbles going all the way through. So air appears bright, and sometimes when you don't want to see it, it's like, okay, patient's unstable. I'm like taking a look at their abdomen. And they have ascites, and I'm seeing little bubbles in there. That's not good. That means gas in the ascites because they have a perforation in the colon. I've seen gas within the bowel wall, which is, pneumatosis coli, which is also a problem. And so once you start like doing more and more ultrasound in these areas where there's no other imaging, you start to have these other findings. So, okay. So B lines, we just talked about, right? So bright, so that's that interface between like, okay, this one was filled with air, with fluid, this one's filled with air, and so it appears bright, and this one's filled with fluid, and so there's this kind of like back and forth, like I just talked about, right? So rain down artifact is what it's called. That's what a B line is. But it's an artifact, and it signifies something in the alveoli or the interstitium. So, and what's cool about these is, okay, so we had a patient in the NIH a couple years ago. He was a psych patient and also had very serious medical issues. And he became really agitated, and his blood pressure shot up to 220 over 120, and he was short of breath on the floor, and they called the code blue. And so in responding to that, what is the first thing you think of? The patient's blood pressure is elevated, you think of like flash pulmonary edema, right? But he also had emphysema, and he was a smoker, and could he have, popped a lung, and maybe he's short of breath, and that's why his blood pressure shot up. You don't know, right? Could be chicken or the egg. So I took a look with the ultrasound, and I see this exact situation with like multiple, almost confluent B lines is what we call them, multiple B lines throughout. And he's on the BiPAP, and at that point I'm saying, okay, this looks like pulmonary edema. He was fine this like an hour ago, and now he's hypertensive and he has these B lines. I made my diagnosis, right? But I gave him Lasix. I give him wide open nitro. It's an ER style. Start the nitro, lower his blood pressure, and he starts peeing out fluid, and he's still on the BiPAP. He's not a nice guy. He's quite cranky actually, and didn't want to sort of, like we were trying to talk to him, but he's like not really communicating well. So we're taking a look with the ultrasound. I'm just seeing the B lines go from confluent to 6 B lines to 5 B lines as he's diuresing and he's moving this fluid out of his lung. 3, 2, and I'm like, okay, let's take off the BiPAP and see how he does. Took off the BiPAP, put him on 2 liters, and he's okay, he was fine. But this is in real time. You can use B lines to actually, alter your treatment and watch them change in real time. It's kind of cool. This will be very relevant for the ICU team in an area where like maybe repeated, I don't know how their access to like x-rays, repeated x-rays are or something, but this would just be easy.
So increased more B lines is suggestive of an increased diversity in like the density of materials you're running into.
Yeah.
Okay. Yeah, right.
Yeah, more B lines means more fluid,
Yeah.
if you're thinking of pulmonary edema.
Yeah.
More B lines in an ARDS patient means more fibrosis.
Okay, great.
Okay. All right, so you guys got the B line down. So B line artifact, I think it's just more of an image of that. Okay. When we talked about lung pulse, lung sliding, one thing we didn't talk about was the M mode, right? So let's talk about what happens if you do have a pneumothorax. I showed you the normals first, right? But now what happens when you have a pneumothorax? What are ways that, one you just told me, we looked at it before, no lung sliding,
Yeah.
right? Why do you not see lung sliding when you have a pneumothorax?
Air trapping.
Yeah, so that's air there.
Yeah, that's exactly right. So like
Yeah.
not, so this is, let's say the thoracic cavity. There's air present, and where there is air present, the sound waves are not going to be able to go, they're not going to come back to the machine, right? So it's just gonna be reflected. So they do see pleura, they only see the parietal pleura,
Mhm.
and that's why you still see the bright line. You're seeing pleura, but you're not seeing the visceral pleura slide up against it, because beyond that there's air, the sound waves have scattered, they're not returning back to the probe, and therefore you see nothing beyond that. So you see something bright and nothing beyond it, right? So that is what appears to be no movement behind it. If you have a pneumothorax, you guys know what A lines are now, right? What are A lines? It goes down to the pleura, and then you have the reverberation because there's air present. Can you see A lines if you have a pneumothorax? There's air present.
You wouldn't expect to see the artifact beyond that.
You do, because you still have the soft tissue up to the pleural line, right? And so, and again, the concept is still the same. There's pleura, but there's air beyond it. So instead of an air-filled lung, it's an air-filled space between the lung and the parietal pleura. You understand?
Mhm.
So that you can still have the A-line artifact present. So A-lines can be present in a pneumothorax. B-lines can help you rule out pneumothorax, because once you see B-lines, you know that the pleura is there and that there is lung beyond it. But usually at that point, we've already ruled out pneumothorax with the lung sliding. Okay, so we just talked about pneumothorax, no lung sliding because there's air present in between, right? That's one of the diagnoses. What if you've had pleurodesis done and your lung is adherent? You're not gonna have lung sliding. So that's another way that if a patient has had pleurodesis already, then you wouldn't expect to see lung sliding. What other conditions? That's it for now, and then we will. So, lack of lung sliding when you're actually visually looking at the pleura. Number 2 is M mode, motion over time along a chosen line, right? So this green line is your chosen line, and this is motion along that line that is graphed over time, okay? So we call this the seashore sign, and we call this the barcode sign. So if you see, initially up top, there's no movement, right? There's no movement. Why is there no movement? Because that's sub-Q. Those are like fascial lines or, muscle lines or whatever within the sub-Q tissue. Now, you see the pleural line here. You've identified this bright pleural line. Beyond that, there's movement, right? You see actually, in patients who have a strong cardiac, or a strong heart, movements, you'll see the lung pulse even through movement of the heart. So this is like good movement, basically, of the lung. And we call this seashore sign because it looks like sandy beach and then the waters, right? And this is called a barcode sign because there is no movement beyond the pleura. And that you don't see any movement because you don't see the lung. You just see the parietal pleura and, air beyond that. So there's no movement, and so you see this barcode sign. Any questions about that, barcode versus seashore?
Yeah, in pneumothorax, you said you see A lines. Is the A line spacing still the same?
Yes.
Okay.
Yep. Yeah, this is a good example, actually. You see it.
Okay, yeah, I saw that.
And you would expect to continue to see it march
Okay.
down. Yeah.
Okay.
And I think here, we were trying to show you a long point. So if you are thinking that a patient has a pneumothorax, right? Your trainee in Vietnam just punctured a lung by accident when they put in a central line, right? And then you identify there's no lung sliding. And now what else can you do beyond, you're like, okay, well, I don't think I see lung sliding. Is there a way to say 100% certainty that this patient has a pneumothorax? Yeah, actually it's 100% specific as a lung point. A lung point is that point of the lung that starts, where the visceral and parietal pleura start to abut again beyond the pneumothorax. And the reason this is so helpful is because you can actually see the size of the pneumothorax, even though technically they don't teach you to learn it that way, but anecdotally I can tell you it does work. If you take a look and you slide down another rib space and you see lung sliding, you find this lung point, right? You say, oh, that's pretty tiny pneumothorax. You may just put that patient on a non-word breather and re-image them a little while later, maybe like 10 hours later, and see if it's, even sooner than that, but like, just if they're stable, you would just want to image them at some point to see if it's expanding or decreasing, right? Now, what if you go lungs, you go here, remember over here you have to come out laterally, you're sliding down, There's no lung sliding anywhere, I can't find a lung point, there's no lung sliding all the way down. That's a huge pneumothorax. That one you have to intervene on. So you're going to tell your trainee at that point, yeah, go ahead and put in a chest tube, or you're going to say to your, hey, fellow, there's no lung sliding all the way down. I think this guy has a pretty big pneumothorax, right? Yeah. So you can kind of tell the size of the pneumothorax with this, finding a lung point. Lung point is 100% specific for a pneumothorax. What is it exactly? For me, it was like hard concept to understand until I saw this CAT scan, and so now I show it to everybody. So it's from Life in the Fast Lane, one of the ED blogs. But basically, you start to see you're not seeing any movement there, right? Like you're not going to see any lung sliding. You come down laterally, and you're about here. You're pretty far down already, and then you start to see some lung sliding. So it's that point where it starts to abut again. Okay. Any questions on a lung point? It rules in a pneumothorax. Okay, now we talk about fluid around the lung, which is very relevant and helpful, I think, in just everywhere, but in medicine. People need to know what a pleural effusion looks like on ultrasound. So in this, you're positioning, your indicator is pointing cephalad, so your indicator is pointing up towards the head. Your probe, in this case, which probe did they use?
Probably the curvilinear.
Yeah, the curvilinear probe. Yeah, because you see that broader, right? So they used a curvilinear probe, and they're right above the liver. So this is liver, this is the diaphragm. The way that it's positioned, it's fanned, you just see it cutting out, but it's there. If you fanned through, you would see it. And above that is something anechoic. And it's all around the lung, right? So something anechoic. So this is fluid. This is an example of a pleural effusion. This is an example, it's not the greatest example actually, but this shows you two things. This is, we're gonna talk about this, but when you actually scan her, I want you to try to find the spine. So when you actually are scanning these patients, sometimes it's like hard to see. Like it looks darker there, the patient's obese, you're like, I don't really know what I'm seeing. Let me fan down and see the spine. Reliably, you'll see the vertebrae, right? And above the diaphragm, above the sonographic costophrenic angle, right? Yeah, I said that right. Yeah. Costophrenic angle. Yeah. You're not going to, you don't expect to see any ribs here, any vertebral bodies here. And why is that? Because the sound waves come down, they hit air, they scatter, they don't return, right? So you don't actually see the spine past the sonographic costophrenic angle. But if you have fluid present, you're going to continue to see it. And you can see the size of the effusion. If you just see like one of these, then it's like, okay, that's a trace effusion present. If you see like 6 of these, then that means there's a large effusion present if you continue to see this all the way up. Okay? So the size of the effusion, whether the effusion is present, the spine sign is extremely helpful. I don't know why they don't even teach it in SonoSim for some reason, but it is like what I use routinely. Once I look for a pleural effusion, I always fan down to the spine. It takes an extra 0.2 seconds. It's like very quick. And you want, when you're looking at effusion, some of the things that you want to look for is whether it's a simple effusion, just like black, anechoic, nothing's present, because I can drain that, right? Like when you're, one of your trainees can just put in a needle and drain that effusion, and that person will be breathing better. Now, if I saw something like this is dense loculations within that effusion, right? So you see those, like, it's like honeycomb kind of structure. This is an effusion where I would say, maybe it's something that I will be able to, first of all, I would never do just a simple thoracentesis for this. I would put in a pigtail, and once I put in a pigtail catheter, like a little mini chest tube, and once I put in that chest tube, I would try to do TPA and Dornase and try to like break down these loculations and see if things clear up, and I can do repeated ultrasounds. I can tell you the ultrasound is so much better than a CAT scan to look at loculations. I've done, this is like over and over again, effusion's present, maybe loculation, whatever, or this CAT scan's not really picking up the loculations. I put the probe on and I see something like this, and I say, okay, well that changes management, right? I'm not doing a simple thoracentesis here. So at minimum, I would change my management to do TPA Dornase and try to break down these loculations. But maybe I don't even, if it's even denser, sometimes you're really dense, I don't even try. So I can't do that. I'm calling CT surgery. This patient needs a VATS, right? And that would mean, like, for example, maybe in your hospital, transfer to a higher level of care where they have those types of things available, etc. And do they have CT surgery where you are?
At a different hospital.
Yeah, so it would be, see, I was right. So that patient would need to be transferred. But this is like, this would make that decision, you know? And so it is very relevant. And you can estimate this, this didn't come out very nicely, but you can estimate actually the amount of the effusion by measuring from the pleural separation, right? Or the separation from the diaphragm to the lung. So you'll see the lung floating in the effusion, and you kind of like measure the distance from the deepest angle, and you in cc's. No, let me repeat that. In millimeters, you do that in millimeters. So you do that in millimeters, and you multiply by 20, and that should be the number of cc's that you have. So if, for example, let's say that let's say we measured the diaphragm is here, and we measure this, and it is 20 millimeters or 2 centimeters, right? 2 centimeters or 20 millimeters. What is the volume of that effusion? Remember I said just multiply by 20. Yeah, it's gonna be 400 cc's. So it's a small to moderate effusion, right? So it's a small effusion, I should say. So in any case, it gives you like a little bit of a sense. It's a nice little party trick for when you're doing a chest tube and you're like, oh, let's see how much will come out. But really it's also helpful for, you know, just, and the patient must be sitting upright so you can actually see the full amount of the fluid. If the patient's flat, that effusion is going to layer posteriorly and you won't get the actual amount. But it's helpful to know like how much is in there. You can monitor it, serial ultrasounds to see it's not getting smaller, the patient's still short of breath, now I need to do the thoracentesis, etc. They're very relevant in the ICU. Now, at the extremes, when it's like the effusion is very tiny or the effusion is very large, this formula becomes less reliable. There's much more complicated formulas that are out there that I don't teach because this is so simple, and it gives you the ballpark of like, is this small, is this moderate, is this large, right? That's all we really need to know at that point. Okay. This is called, this is the sinusoidal sign you look for when you think about trapped lung. This is a lot less used, it's not commonly even taught, but I'm just so you've heard it once, in some of these patients with these chronic pulmonary issues, they can have trapped lung within their effusion, you drain their effusion, right, they're gonna have some chest pain, etc. How do you predict that they don't have trapped lung? Well, you're supposed to put the M mode, the motion over time, along the, where you're seeing the lung border in the effusion, and if with each inhalation, it should expand, right? There should be some movement. Now, if they have trapped lung, it's not going to move, right? So that's how you sort of can sometimes, if you're worried about it, check for trapped lung. This is lung consolidation. Remember I told you the interface between the air and the tissue can create, air can look bright. So these are actually air bronchograms here. So this is a patient with a pretty significant pneumonia. And so you start to see those like bright little consolidations. This is what's called hepatization of the lung because it kind of looks like the liver. It looks like a solid organ, basically, is the point. Does it look exactly like the liver? No, I still don't know why we call it hepatization, but you get the point. It just looks like an organ because it's so densely consolidated. Okay, so here, what else do I want to say about this? Nothing here. And then, yeah, the other thing we look for, I already showed you those were bronchograms, right? But there's two types of bronchograms. There's static and dynamic air bronchograms. So, if you see something like this is pathognomonic for pneumonia. Right. So, pneumonia, wish I had looped that. So, that's, again, dynamic air bronchogram, pathognomonic for pneumonia. I don't really know why, but my sort of understanding of it, my own sort of, this is what I think is happening. This isn't what's taught. They're just sort of like, we don't know why this appearance happens. I think it's a mixture of air and mucus within the bronchioles, right? So as things are moving, you sort of see movement. And so when are you going to see mucus within the moving? You're going to see that in pneumonia. So that's why it's pathognomonic for pneumonia. In pneumonia patients, you'll see dynamic air bronchograms. What about static air bronchograms? They are present in atelectasis. You'll see this routinely in ICU patients at the base. You'll see atelectasis present, and so you see static air bronchograms. But what if you see it all the way up in the lung? What if you see like a major area of static air bronchograms? Is that pneumonia or is that collapse of the lung?
It's like collapse.
So I had a 16-year-old that's suburban in the ICU. I was moonlighting. I walk in and he just looks bad. You know, like you get that clinical like, you don't look right. And he's 16. He got shot in the abdomen by a ghost gun in high school. Isn't that crazy? But and they take trauma patients down to 16 over there. So he's shot in the abdomen. He looks bad. He's kind of breathing like. Respiratory rate's a little fast, not like tachypnic to the point of intubation. He's satting pretty good. He's on, 4 liters nasal cannula, satting 94%. He's okay. He has not been febrile. He's getting around the clock Tylenol. He's getting around the clock Zosyn. So I'm like, okay, he's on antibiotics. You think about, he's on NSAIDs also for actually pain control because he's several days out from his abdominal injury. So the first thing I think about is like he's already on antibiotics. He's probably atelectatic, right? He's probably got critical atelectasis now. He's breathing shallow because he's splinting from abdominal pain, right? So I take a look at his lung and I see static air bronchograms, but pretty far up on the left side, like all the way up. And I'm kind of like, that's like a little dramatic. He's not intubated. He just has a nasal cannula. So I can't just go down there with a bronchoscope and take a look and see if he has a mucus plug or what's happened, right? So I'm like, you know what? I'm going to send him for a CAT scan. I messaged the trauma surgeon. I say, I'm going to send him for a CAT scan of his chest because I'm seeing static air bronchograms on my ultrasound. By the way, the nurse said to me when I walked in, they said, this is how he's looked, he's fine, right? But it's like, this is how he's looked for 2 days. And kids are scary that way. They look good for so long until they fall off. So he was actually hanging in there, but I just did an ultrasound because I was like, I don't know what's going on, and he doesn't look right, and that's what I found. Anyway, so I sent him down for this CAT scan, and I told the trauma surgeon, I said, I see static air bronchograms, which could mean atelectasis, that could mean pneumonia. 30% of the time it's a pneumonia, and 70% of the time it's atelectasis, right? So I'm thinking, well, could just be. So I send him down, and lo and behold, he has this huge pneumonia, right? Like it's like his entire lung is consolidated. So I send off his sputum culture, I escalate his antibiotics to meropenem, right? So now he's on a carbapenem, he's already on Zosyn for many days. He grew an ESBL organism. So the ESBL organism was why he was not responding to the Zosyn and why he developed a pneumonia on the Zosyn, because and he was septic. So meropenem, the next morning I come in, because I did my weekend, so it was 2 days on. I come in the next day and he's like, hey, how's it going, doc? And he's like a different kid, right? And so, and to this day, the trauma surgeon is always like, hi, Sadia. He's like, like, he was so nice, and he gave me a follow-up on what happened with him, and he did well, and he, left but I was like, I didn't do anything but ultrasound, but it gives you a really good sense of things, and I bring up the story because this was this whole idea of static versus dynamic air bronchogram. Had I thought static air bronchograms, atelectasis only, I might have gone down a different pathway. I might have said, I wanted just chest physiotherapy, etc. You have to know that in these patients, it could be pneumonia. Yeah, it could mean either one, okay? All right, so that's my whole little pre-scanning spiel, and so that gets us to 12:17, and now we have 45 minutes to scan Neha. And ourselves, really, like I would encourage you to scan yourself. So let's go this way.